Good afternoon, everyone. Thank you so much for joining America Abroad Media and the Berkley Center for this special Beyond the Broadcast discussion on Africa's Holy Healers. If you all don't mind, we are taping the event today for posting on Berkley and AAM's website, so I'd ask you to please turn off your cell phones, turn off any Wi-Fi applications because it can mess with the taping. Very much appreciate your help in that regard. My name is Emily Simon. I am the special assistant to Aaron Lobel, who's the founder and president of America Abroad Media. He is traveling back from an extended trip in Afghanistan and Pakistan, and I am delighted to welcome you all here on his behalf. I'd like to extend a special thanks to Catherine Marshall for all of her advice on the public radio program, as well as her assistance with today's discussion. In addition, we're grateful to Hannah Friederici and Claudia Zambra of the World Faiths Development Dialogue, as well as Abby Waldrop of the Berkley Center for their help in coordinating this event. And finally, we'd like to thank the Henry Luce Foundation for their support of the public radio program and of today's discussion. AAM created the Beyond the Broadcast series as a way to encourage in-depth discussion of the critical issues presented in our public radio programs. Africa's Holy Healers was originally released in June and has since been airing on public radio stations across the country. Some of you might have heard it on WAMU. If not, we've provided a copy at the seats and would very much welcome your feedback. My business card is in the packet, and please feel free to email any comments, questions. Very much welcome your comments. Just to provide you with a brief overview of the schedule for today, we'll have about 25 to 30 minutes of discussion with the panelists and then open it up to a Q&A with all of you. We envision all of our Beyond the Broadcast events as interactive conversations, and I encourage you strongly to contribute. We have a lot of folks here who work closely on this issue every day, and I know we'll have much to contribute. I'm delighted that we have a terrific group of panelists with us here this afternoon. I'll take a minute to introduce them. First, we have Michelle Bromelsek in the blue shirt. She is a seasoned international development specialist with over 15 years of experience managing multinational, multifunctional teams in resource-poor settings. Since 1995, she has served in various capacities with Catholic Relief Services, the international humanitarian agency of the Catholic community in the United States. Ms. Bromelsek currently serves as Chief of Party for AIDS Relief, a 5-member consortium funded through PEPFAR, with CRS as the prime grantee. And in this role, she works with consortium partners to administer the more than 500 million grant, which currently provides ARV therapy to more than 190,000 people. Since 2004, AIDS Relief has provided care and treatment for nearly 500,000 people living with HIV. Prior to joining AIDS Relief, Ms. Bromelsek was the regional director of the CRS Southern Africa Regional Office. She served as the CRS country representative in Zambia, where she helped assemble the initial AIDS Relief proposal and supported the consortium for its first 3 years. Then we have Andreas Hippel, currently serving as acting executive director of the Center for Interfaith Action on Global Poverty, an NGO that seeks to increase the collective impact of the religious sector on global poverty and disease. As CIFA's director of programs, Andreas has led CIFA's technical support for the development of the Nigerian Interfaith Action Association, a new NGO led by Nigeria's highest Muslim and Christian faith leaders. They have trained nearly 20,000 pastors, priests, and imams to advocate life-saving behavior change related to malaria prevention and treatment. Prior to CIFA, Andreas worked as an independent consultant, and his background includes 2 years as a small enterprise development advisor for the Peace Corps, as well as significant experiences in countries throughout Africa. He holds an MA from Johns Hopkins School of Advanced International Studies and is currently completing his PhD at SAIS. He also was an Africanist doctoral fellow at the Woodrow Wilson Center in 2007. Across the table, we have Hope Sukin, Senior Health Advisor for the Africa Bureau in USAID, and she is leading the Africa Bureau's health team. She provides strategic and technical guidance to the 25 USAID missions in Africa that manage and implement health programs. Her technical specialties include nutrition, maternal and child health, HIV/AIDS, and health system strengthenings. She also represents USAID as one of the deputy principals to the PEPFAR program and works closely with both African partner organizations such as the African Union, West Africa Health Organization, and the WHO. She has directly provided technical support to country health programs across Africa. She holds an MPH from the University of Michigan and a BA from the University of Pennsylvania, and in 2009 received the George C. Marshall Award for more than 33 years of leadership in health at USAID. Dr. Quentin Wodan is the advisor and program manager for the Development Dialogue on Values and Ethics, the unit in the World Bank that manages the bank's work on ethics, values, and development. He joined the World Bank in 1998, first as an economist and then as lead poverty specialist for West and Central Africa, where he focused on policy research and capacity building initiatives. He is the author of more than 12 books and numerous papers on economics and development. He holds a business engineering degree, an MA in economics, and an MA in philosophy from the Catholic University of Louvain, as well as a PhD in economics from American University. And finally, that brings me to our moderator, Catherine Marshall. She needs no introduction. She's a senior fellow here at the Berkley Center and head of the Center's program on religion and global development. She also serves as a visiting associate professor in the Department of Government and is executive director of the World Faiths Development Dialogue. She has nearly 4 decades of experience on a range of development issues in Africa, Latin America, East Asia, and the Middle East. She's the author of several books about development and also writes the Faith in Action blog for the Newsweek Washington Post website on faith. And now, to begin the discussion, I would like to introduce Jordana Gustafson, who is a correspondent for America Abroad. Jordana traveled to Kenya this May to report on the intersection of religion and public health, and she's going to kick things off by sharing a few anecdotes and clips from her time on the ground. Jordana.
Hi, everyone. My name is Jordana. So the premise that we started with that interested us in this topic to begin with was that 40 to 70% of healthcare in Sub-Saharan Africa is provided by religious organizations, or faith-based and religious organizations. And when I first heard that, I kind of immediately thought of World Vision or Samaritan's Purse, and then kind of came to realize that we're talking about local congregations, we're talking about international congregations, local congregations, international congregations, local and international NGOs and nonprofits, as well as mission hospitals, which have been there, years. And for many of the countries, the health systems grew up around the mission hospitals. So in Kenya specifically, I was told by one of the women at the U.S. Aid office that Kenya receives more money than any country in the world from U.S. Aid. And her particular office, which now I wish I remembered exactly what it was called, but I think it was Health and Global Population, or Population and Health, receives $384 million a year from U.S. Aid. And the woman I spoke with estimates that Kenya actually receives, that the amount of money coming into the country from faith-based organizations and religious institutions exceeds that number. That's, a lot of money. And so I went to Kenya to kind of see how this plays out, and it was a pretty broad mission that I had to look at how it works. So one of the first places that I went to was an eye clinic in Kibera, which is one of the world's largest slums, part of Nairobi or just outside Nairobi. I happened upon this clinic. It was being held by by people from a congregation in Texas. It was a Lutheran evangelical church, and over the course of 5 days, they served 2,000 people. And in this part of the slum, it was heavily populated by Muslims. And when I got there, they had a tent set up, and so many of you work in this field, you've probably seen this many times. There's a tent set up, and a Kenyan pastor was giving a talk about Christianity and about Jesus, and he was showing them a sort of Rubik's Cube thing that he moved around to highlight his talk with illustrations that were painted on the cube. Anyway, so I spoke with the pastor there, who happened to be an American. He was married to a Kenyan woman, and this is what he told me.
Well, I think it's a wonderful care for the community because they can come here and be treated. But I also think it's the best evangelism outreach that can be, because you're loving your neighbor. You're being Christ to the community.
So being Christ to the community. So this is a community that I said was heavily populated by Muslim people. And there were many Muslims who were waiting under the tent and waiting for care. So one of the questions that we had was, is there any element of coercion when you have religious organizations or institutions that are providing health care? Do people feel that they have to convert? Do they feel pressured to sit and listen, to talks about something that they don't believe in? And before going in speaking with people from different organizations, from both secular organizations, I was hearing from aid workers stories that, for example, they saw one organization somewhere in Africa where they lined people up according to their church attendance. And I heard different things like that, so I was interested in seeing if that were true. But the interesting thing to me was that was a pressing ethical question that we had, and that we had here in the U.S. And when I got there, it seemed almost irrelevant. I mean, it's never irrelevant, but that wasn't a pressing question for anyone who I spoke to. And I spoke with a minister of health in the government. I spoke with people from secular organizations, non-secular. I spoke with a sheikh, with different pastors, and with people who were receiving care, and I kind of stopped asking the question because no one had any issue with it. And there are a couple reasons that I found, and one was that Kenyans are so religious that it didn't seem odd to them to have religion enter the sphere when they're receiving health care. And earlier this year, there was a study out, a Pew study, that showed that nearly 80% of Kenyans pray at least once a day. And so when people were asked to pray, even if they were Muslim and it was a pastor or the opposite, it didn't seem to bother them. And I was told by people in different organizations there that there was a general tolerance of that in meetings. Someone might start out a meeting with a prayer, and everyone bowed their heads and was happy to pray. And so I spoke with a woman. What was I going to say? Oh, and the other thing is that as I said before, that a lot of the countries, and certainly in Kenya, the health system grew up around the mission hospitals, so it's kind of always been linked for them. And then the second thing was that there was such a deep need. In Kenya, it's one of the more developed countries, or one of the most developed countries in Sub-Saharan Africa. They do have a functioning healthcare system, and they work closely with international agencies they're working closely with international agencies to reform the healthcare system so that it is further reaching, and so that the supply chains are better, so that they're better staffed. But as the health minister told me, they still have a very long way to go. It was suggested to me by a woman with the International Rescue Committee that in some areas of the country, 70% of healthcare or more is provided by NGOs, faith-based NGOs and organizations and congregations. So a Muslim woman who was at the eye clinic kind of corroborated all of that. I'll play you a clip from her.
The main concern is people's health. And if faith-based organizations come up with that, then I don't feel bothered at all. I think that is the right thing they're doing, the most right thing that they're doing. So that is why you find that if it is a Muslim organized health clinic, people go. If it is a Christian organized one, people still go because they have to stay healthy.
And that was Siyama Ismail, and she had also told me that when the pastor asked her to pray, she was very happy to pray with him, that they were praying to the same God, even if they had different beliefs. So then the other thing that comes up, and this is something that I didn't look at because my colleague Matt was in Uganda looking at this, and that's obviously reproductive health and family planning, and that's where probably the biggest rub is. And so I spoke with a community activist in Maasai land in the southern part of the country, and I just wanted to share this because it was cute. He had been trying to bring condoms and family planning to his village, and it didn't work. And so here's him sharing that story.
I remember we tried to implement we tried to implement a program of distributing condoms in the village. And, I called out young people in the village and I told them, we are going to identify certain trees in the forest where we will be dispensing condoms. We will put condoms there and people will be picking from there. And these young people just told me flat on my face that don't attempt to do it. Don't attempt to do it because you'd receive so much rejection.
So he's kind of laughing at his own folly there, thinking that he could easily bring condoms to the community. So one of the things that it sounds like Andreas does or works with, and I don't know who else does, but the big organizations, secular organizations, work with different faith leaders in the country to come up with health education materials, where they will cite scripture from the various or from the respective religions to try and teach people things like family planning and showing them that it's okay, for example, to use condoms. So that hasn't yet made it to where this guy is from, but that's another thing that I got to see while I was in Kenya. So that's all I have to say.
Thank you. I guess it's over to me. Catherine Marshall, and my first task is to welcome you warmly to the Berkley Center at Georgetown University and to thank all of you for coming. This is a fascinating topic, and we have been excited to be partners with American Media Abroad, and it's a wonderful program, so recommend very much that you listen to it. What we're going to try to do is to have a lively exchange within this panel of diverse organizations and approaches, and then open it up. So there are no presentations, it's all an exchange. So let me start right away. The first topic that we want to explore is, in a sense, what makes these faith-inspired organizations different? Is there a DNA which you can identify? Is there some characteristic? How are they different from NGOs, FBOs, NGOs, faith-inspired organizations? So to start that, let me ask Michelle, who works with one of the largest of the faith-inspired organizations, CRS. How would you answer that question? Is it different? Is it the same? If so, how is it different? Does it matter?
Okay. Do I take the... Thanks.
And I guess just for clarification, you're asking first for CRS as an organization or first for the organizations in Kenya? Are we focusing at
No, we're global now.
We're global.
For Africa. And not specifically CRS, but how do you answer this question?
Yes.
Which many people ask.
Yes.
Is there a difference? Should we care
Okay.
that there's a faith link?
Okay. I think, obviously, I work for CRS, so I'm a little biased in that I come from a faith-based organization. I've worked for CRS for 15 years in a number of settings around the world. And I think our partners of preference in the countries where we work tend to be faith organizations, not always Catholic, but often Protestant, Muslim, Hindu, in those countries where we work. I think many faith organizations come to this work of reaching out and helping those in need out of a feeling that it is part of their responsibility to serve those who suffer. So I think that's one aspect. That doesn't necessarily mean that you can't be a non-faith organization or a non-faith-oriented organization and not believe in that, but that sense of reaching out and trying to make a difference on people's suffering, I think is a real driving force. And so the people who come to that work, whether they themselves are part of that faith, so for example in CRS maybe not all of our staff are Catholic, even though we're a Catholic organization, the people who are drawn to that work are drawn because they want to make a difference. I think in the countries that we're talking about in Africa, faith-based organizations are critical. I can't tell you enough myself of what a difference a faith-based organization makes in healthcare. If we're looking at Sub-Saharan Africa and we're looking at rural areas, we're looking at organizations that have a deep and abiding focus on the community and how you bring that community together to solve the needs of that surrounding area. So even if you're talking about a faith-based hospital or mission hospital, they're not going to be just talking about whether the people who walk through their door are served. They're going to be asking, is there a well in the community? Do the people need help with shelter? So I think part of this is that often faith-based groups are looking broader and are found in many parts of Africa in the rural areas where you will not find, in many cases, NGOs.
So I think you're focusing on the drive and the motivation. You're driving on the links to this extraordinary faith network and to the broader sense of community. Andreas, you are working on the bridges between the secular and the faith organizations. How do you think these organizations, these institutions are seen? What are the positive sides? But perhaps you could also mention some of the hang-ups, some of the concerns that you're seeing in approaching this large group.
Sure, absolutely. Thanks, Catherine, and thanks for having me as a part of this event. The bridges between the public sector, and I'm going to give a little reference to a project that we're working on in Nigeria with an NGO that we helped set up there with the top Muslim and Christian leaders that was mentioned earlier. The links between the public sector and the religious leaders specifically, and I'm going to talk about religious leaders specifically because I think it's important to actually distinguish between faith-inspired and faith-based organizations that are essentially professional, development-related, health-related organizations, and efforts that seek to engage specifically imams, pastors, priests, and so forth, religious leaders themselves. There is an advantage, I'd say, to, first of all, speaking to people in the language that they speak about themselves and their lives in. And in the case of Nigeria and in the case of most of Africa, the language of religion, the language of belief infiltrates every aspect of life. So to the extent that a health-oriented project or organization can use that language or speak in that language as well, it helps a connection, it helps build credibility, it helps build trust. I think it also helps communicate and facilitate messages being delivered and understanding how people see themselves. I work for a secular organization that has people of multiple faiths and of no faiths working for it. That gives us a certain neutrality in working with Muslims and Christians and others in the context where we work. What we find is building the bridges between those who do not want to necessarily speak the language or do not necessarily know how to speak the language of faith is not always easy. There are the big international donors, the World Bank and others, who have quite a number of people who understand the faith perspective and understand that it's hugely important. We have Quentin and Catherine are leading examples. They are the cutting edge of this, certainly. At the same time, there are people who see faith from a secular point of view and perhaps with some element of suspicion. We can think of the first half of Ray Suarez's segment on this program, where historically northern Nigerian imams and religious leaders were part of the problem in relation to polio, the vaccine initiative in polio. They're bridging that divide basically is a question of education of the faith leaders, getting them to understand what the specific implications of their actions are, and understanding why the interests of their personal communities, their local communities, may be best served by an ongoing dialogue with the public sector, and educating the public sector on how to interact with the faith leaders. It's a process. It's slow sometimes, but I'll stop here. But I think there's hope for it in a lot of Africa.
So you end on a note of hope. Quentin, how much do we know, and what are the knowledge gaps? And I also can't resist asking you if you can give some sense of what this is an area of great expertise, we've done a lot of work. How do you deal with all these wildly differing numbers that are floating around on the issues of the share of health care, its quality, its reach, etc.?
And that's a big question, Catherine. Perhaps before I talk about market share or these numbers, let me go back to the first question you asked, because that's a fundamental question. You asked, to what extent are faith-based organizations different? And to me, the question is, to what extent are they different for development outcomes? What we are looking at is development outcomes in health or in something else. And there is actually very little evidence that they are different. There is a common belief among faith-based organizations, and I would agree with that, that they are in some ways different. Whether it matters for development outcome is not clear. The question then is more, as you said, to what extent is the quality of the services that is provided different? To what extent do faith-based organizations reach the poor, more or less? To what extent do faith-based organizations have different priorities as opposed to other organizations? Now, on the quality, the evidence, there is less on health actually, there is more on education, goes both ways. In some countries, faith-based organizations are doing better. In other countries, they are doing worse. On who reaches the poor, in some countries, faith-based organizations, and again, we have a bit more evidence on schooling than on health, reach mostly the better off because they tend to have very high quality programs, which may require also more funding and so on. So with cost recovery, then only the better off would go. In other countries, faith-based organizations are mostly serving the poor, but there is no real commonality there. The situation is very different. On priority, there is one study that I found very interesting, and this was done a few years ago by colleagues at the World Bank. And this was about health, and it was in Uganda. And essentially, the question was, if you provide untied money to a local health center, and the health center is able to use it in any way it wants, what is it going to do with it? And the test then is whether a faith-based organization, this money was actually provided to faith-based organizations. Are they using it for themselves, which is for raising salaries, raising perks, or something else, or are they going to use it for the clients who are actually seeking care? And this is the only study that I know that managed to test that. And what they found is that indeed the faith-based organizations were very altruistic, meaning that every bit almost of the money that they got untied was used to provide more services and cheaper services. That is a good start, but that is not something that necessarily makes faith-based organizations different from other non-profit organizations like NGOs and others. Now, I go back to that because it's very important that we ask the question, in what sense are they different, for what? And my feeling, after now 2 years working at the World Bank on some of those issues, is that what we have to look at is the role of non-state providers, including faith-based organizations, and they are the largest non-state providers in many countries, in terms of how they help and what they do. Let me ask you, just say one more thing about to what extent are they different before going to the market share, if you want me to spend time on that.
Quickly.
But very quickly. The situation is fundamentally different, I think, between health and education. And we just did work, qualitative work with household interviews, focus groups, and so on in Ghana and Burkina Faso. For education, faith matters dramatically in terms of the choices made by parents on where they send their children to schools. For health, the data suggests that actually the faith aspect does not matter too much for where individuals who are sick are going to seek care. And so again, I think that it's very important to disentangle those questions, to look at various sectors, various countries, because the answers are often very context specific.
And the market share?
Okay, quickly on the market share. I mean, I have, I guess, to mention...
The estimates are somewhere between 10 and 70, 80%. That's a pretty wide range.
The estimate that is quoted of 40 to 70% is actually an estimate that comes from one study that did not provide that estimate. So it is a study that was very localized in countries where faith-based organizations had a very large market share. Actually, the study specifically says that it cannot be used to provide that estimate. That's the one study. I won't mention which one it is. Now, if you look at data from the faith-based providers in terms of the share of hospital beds and things like that. Then you would tend to have, in many countries, not in all, a market share of about 20 to 30%. But because that is only part of the health sector, when you look at household survey data that have information on where people do seek care, the share is more like 10%. In many countries it's lower. In some countries, a few, it's higher. Actually, the market share is much lower, it seems, for health in some countries than for education. Now, to me, I think we would be better off not having this 40 to 70% estimate floating around, because I think it is an overestimate. It might be much higher than the 10 or 12% that we get in household surveys. But that is not the key question, because to me the key question is, what can we learn from what faith-based organizations are doing? How can we integrate them in national responses to attempts to aim at some of the MDGs? And for that point of view, the issue of the market share is not irrelevant, but much less important. The issue of quality, the issue of cost recovery mechanisms, how much does it cost for households, the issue of the priorities of the managers of these organizations become much more important than that of the market share.
Well, I think that gives a good flavor of the debates, which are quite lively. Hope, you are dealing with USAID as well as PEPFAR. I think the first simple question really is sort of, what is the U.S. government's approach on this? I think an interesting question also is, what changes are you seeing? Is there a big change from one administration to the next? And where are the points of tension or uncertainty?
Sure. Maybe I'd say first that in Africa, you can't do development, certainly not good development, without really understanding religion and being respectful. And as has been said here, religion is such an important part of Africans' everyday life. It affects food choices, it affects practices in feeding children, personal decisions, decisions about how you relate to not only your family, but the community. So you really do need to include and integrate religion in whatever we do in development. And I'd say a good development practitioner for decades should be doing development like that. I think certainly with PEPFAR, I think under the last administration, there was a much higher emphasis on making sure we integrated faith-based organizations into what we were doing. I was even looking at a quote here recently. This was from Rick Warren, who came into the White House, I guess, 2007, and said something, there is need for public, private, and faith partnerships to address the AIDS epidemic. And certainly with PEPFAR, I mean, Catholic Relief Services, World Vision, with the increase in funding like you saw in Kenya, I think that with that increase, we're seeing significant funding increases going into faith-based organizations. And they are the ones in many countries who truly do have that outreach into the communities. I was just in Ethiopia and Rwanda, and what really struck me, as it has in many other countries, is when you go out to rural areas and you go out to the communities and you see these groups who have been mobilized for care and support of HIV/AIDS infected people. Many of the faith-based organizations are the ones who have organized these groups. You see the poorest people, both men and women, older children, who are infected, who have so little and are giving to those who have so less, because these are members of their community. So I certainly think that with PEPFAR, with the President's malaria initiative, and now even more with our maternal and child health programs and our family planning programs, as we are reaching out more to the communities, because we really see that's where we're going to get impact. The faith-based organizations, both the international and the local, are becoming just stronger partners with all of us.
Well, thank you for these thoughtful responses. Let's turn now to the question of HIV/AIDS. In many ways, HIV/AIDS in Africa has opened these issues up in ways that they had never been discussed before, and presented challenges that no one's ever seen. And you have a very two-sided story. Now, you have the story you're referring to of the extraordinary caring that so many different religious communities have shown for people and families and communities devastated by the HIV/AIDS virus. You also have had what people describe as faith as part of the problem, particularly with stigma, but also with sparking what are often quite bitter debates, and not even debates, shouting matches about different approaches. So Hope, do you want to comment briefly on how you see, is this a case where faith is a detriment to public health? How do you frame this, the different dimensions of religion as part of the problem and part of the solution?
I think certainly with HIV/AIDS, and even before that with family planning, there were differences. And, I remember in Mali years ago, I'd been in a meeting that had brought imams together from 5 or 6 West African countries. And it was a start of a real dialogue, actually led by imams, who felt that some of the communications to their congregations about not using condoms, not using contraceptives, perhaps were not the right ones. So I've seen in Africa, probably beginning at least 10 years ago, more of a dialogue between many different religious groups and the government and development agencies. I also remember in one country 5 years ago when we just brought in PEPFAR funds, talking to a religious leader who absolutely was saying that condoms were evil and that he was telling his congregation that. So yes, I think that information that has gone out has been not helpful in what the science tells us it's needed. But I've also seen over the last 5 years an incredible increase in the dialogue with really very good forums that have been led by religious leaders to inform other religious leaders about what the science says, about what the Quran says. And I think that education has gone a really long way, and more is needed.
I think I would reinforce that comment, but there still is an issue, and I'm going to turn to my left, to Michelle. I know personally in my experience, every time a Catholic bishop makes a pronouncement that condoms have holes, 20 people send me a copy of the press release with a basic message, "We told you so." So how do you deal with the Catholic Church position?
Thank you. It's good I've had a lot of practice answering this question. I think that what we have to keep our mind on is what is the Catholic Church trying to do in this whole fight with AIDS. And I think the battleground in the field is about how do you create positive communities? How do we all try and deal with this terrible disease that is killing people? And certainly, I don't disagree that there are many points of view, and I would definitely agree with Hope that the dialogue has radically improved over the last 5 years. I mean, we can go into, I think, the individual positions of bishops. I think it's more helpful to think that what the Catholic Church is trying to stand for is about being for positive living, trying to find a way in their belief set to really help people and to find a way to come up with options for people that are about making positive life choices. Now, you can say, oh, it's all about the negative, but it is also, I think, in many cases, also about the positive. When we engage young people in thinking about delaying sexual debut and making good life choices, and when we talk to married couples and we work with them on how to talk to each other about finances and life and children, we're going to have better societies. And we're probably not the organization to come to ask for certain approaches in prevention, but the truth is, prevention is a spectrum of responses. And when we prevent mother-to-child transmission of AIDS, when we encourage young people to make the right choices and couples to care for each other, I think we're probably part of the solution and maybe not part of the problem.
I think that's a fantastic answer, but I think the concern of people who see the importance of the faith roles is first that the focus on the policy can obscure what people are doing at the field level and the absolutely remarkable people. Plus, it does have a spillover effect into issues that are very, very far away. So, Quentin, I wondered if you would like to comment on how you've seen, as you've come into this field, in a sense, the role of the HIV/AIDS debates as part of the broader approaches and the broader dialogue.
Okay, this is not a comment on the Catholic position. So, no. I mean, a few things. I mean, first, I said before that the evidence on service delivery for general health services is actually somewhat different from the discourse, which doesn't mean that faith-based organizations don't have a huge role. They do, right? Now, to me, an issue like HIV/AIDS, or more generally the issue of congregation-based initiative or community-based initiative, is actually where faith-based organizations have a very clear, at times, comparative advantage, not always. But so I think that there, the congregations are doing a lot of things that nobody else often would do, and that has to be recognized very clearly. And I would say that after 2 years working on this at the World Bank, because I'm new to this field, when I came into this job, my impression was that work on the role of faith-based organizations in service delivery was the most important work. Actually now, I believe in talking to a number of UN colleagues, they believe the same thing. Work on how faith and values affect behaviors is at least as important. And that's why, again, the community-based role is important. Now, I think what we have to do, again, from a point of view of development outcomes, which is slightly separate from the issue of specific policy positions, is to really understand better what is going on. And my colleagues in the HIV/AIDS program at the World Bank are actually doing right now a study to evaluate community-based interventions, which is faith and not faith. And we had a meeting yesterday, and we were discussing, how are you going to actually document what is going on? And they did some preliminary work that they were showing. And so we had a matrix for 5 areas in Kenya. In each area, there was an inventory of who was doing what. And it's just amazing, because you have about 15, 20 organizations in each community. I mean, these are not huge communities that are doing completely different things, and sometimes the same thing, right? And so the first priority, I would say, is to try to better understand what is going on and to achieve synergies between what very different groups are doing, because often, otherwise, you don't achieve critical mass. So that maybe doesn't answer directly your question, but it's a point. Now, I just want to make one additional point. It is the fact that funding for the role that faith-based organizations have in HIV/AIDS has increased. But again, my colleague found out by looking at different sources of funding that right now, according to their estimates, it's in the range of 7% of total funding that is going to work by faith-based organizations on HIV/AIDS. Now, I do believe that on HIV/AIDS, actually the market share, if you want to call it that way, of faith-based organizations and more broadly community-based organizations is much larger. So if we can go beyond the issue of specific positions, and as you know, there are also a range of positions on this, I think there's much more to do on the areas of agreement than on the areas of disagreement.
Andreas, SIFA took on the issue of malaria, which has an attractive feature that there's very little sex involved. And therefore, in a sense, the positive synergies are easier. I wondered if you had a quick comment on that.
Absolutely, and you've hit the nail on the head. It's a much easier issue to deal with because of exactly what you said. That said, I think the same questions that Quentin just raised about impact and measuring and evaluating the actual impact to get at what Quentin said is a potential comparative advantage of religious leaders. That's universal across these sorts of interventions, and we're actually working with some of Quentin's colleagues at the World Bank to integrate the work we're doing with a malaria impact evaluation survey. On AIDS, I think one of the things that we always have to remember is that the faith-based approach doesn't ever happen in a vacuum, and to the extent that we can pinpoint and figure out where the real advantage of the messaging through faith leaders or through faith-based organizations is, then we can know better how to program other aspects of HIV/AIDS interventions and see what aspects of behavior change messages or other services or service delivery needs to come from other sources. So.
Well, we have about 5 more minutes of the panel discussion, so I want to have a quick reaction from each of you on one of the topics that the program addressed and that we know is particularly sensitive in many settings, which is the issue of proselytizing, evangelizing, depending on how you use the term. So let me ask, in a sense, the least likely person on this one first. Quentin, is this something you hear about? And then maybe we can go to Hope, where I think it's probably a much more explicit issue in the discussions.
Well, maybe I can make 2 comments. I mean, first, that issue is very important. It's important on the ground in terms of the services provided. It's also important right here in Washington, D.C., with my colleagues at the World Bank. And it is not always easy to ensure that the role of the faith sector is given its due and its recognition because of that issue, because of the fact that we are a secular organization, and some people are still very concerned about the attention that we give to the world of faith in development. I think we need to give that attention, and the bank has been doing it for a dozen years or so, but it is something that is not easy because of that, essentially. Now, on the ground, I actually don't have any data on knowing whether this is something very common or not. I could say 2 things. I mean, anecdotal evidence suggests to me that it is not very common. And I would probably agree with what was presented in the beginning, that for many people, as long as it is done in a not an extreme way, it might not be that bad. That doesn't mean it should be done. That's a different story. Now, where there is quite a bit of information, and I just mentioned that as my last point, is on whether faith-based organizations are serving the various groups. Because actually the household surveys that I mentioned before, which enables us to look at who gets care where, we have information on the faith of the individuals. And it is clear that especially for health, a bit less for education, but especially for health, these faith-based organizations are serving everybody. And so if people from another faith continue to come to a specific faith-based organization, that probably tells something. So again, we would of course prefer to have no proselytizing, but probably that issue is overblown in terms of its importance as compared to other issues.
Thank you. I also haven't really seen data on this issue, but I travel to probably at least 10 countries every year, and I really haven't heard this brought up as an issue. And I think too, as in Kenya, my experience just in Ethiopia and Rwanda too, is that people are so set with the religions that they have that it's a very tough sell to try to change that. And also, as I've been in many of the facilities, hospitals, health centers, they are, these facilities are very professional, and the staff is very, very professional. And I really haven't heard any conversation at government levels or at, local health government levels that this has been an issue. And maybe, if this continues to be an issue in a broader dialogue, maybe it is good to have some real data and either put it to rest or, address it in the most appropriate way.
We have in the Berkley Center, in a number of our studies, done a lot of interviews. We have well over 100 interviews, and one of the questions that we ask is about the appropriateness and the mechanics, etc., of evangelizing. It's a complex question, but my rough data is that 97% of the people involved would answer that there should be absolutely no link between the evangelizing and the service delivery, but there is a significant minority that takes a view that you cannot separate them. So, that's okay.
I would say, in my experience in Kenya, everyone from the different organizations, the international organizations that I spoke to, they will say we do not proselytize. Well, they know they have to say that, because if they say that they do proselytize, and they won't get money from USAID, for example. So, but if you keep pressing, for example, I was speaking with a guy from Samaritan's Purse. Oh, well, we have a parallel ministry. Oh, well, where do you set that up? Well, it's right next to the clinic.
Yeah.
And we let people know that they can go to the, to that or whatever. And I think that that's what different organizations do. And then one other thing, I called every mega church in the country almost. There's 1,400 of them or something. And many of them, they say, yes, like proselytizing is absolutely part of their mission when they're over there. And one guy described going out to the desert in the Serengeti and putting a huge television screen on top of the van. I forget what it was called. I think it was called the Jesus Video, which they played for the Maasai in the desert. And a lot of congregations had stories like that. So I think it's very common. But again, I didn't actually hear anyone say that it was an issue for them or that people weren't serving people of different faiths.
Well, no, we've heard a lot of people say that it is a serious issue, and including, interestingly, many Catholics, the orders, etc., who have found that some of the aggressive evangelizing, they say, undermines their work. So I wondered if you had any insights or experience on that.
I do think we need to probably make a real clear distinction between organizations that send mission trips over to a country that tend to be maybe a one-off or an annual visit where they go in and do an eye clinic or do some other type of activity, and it's sponsored by a group here, and the people who come are all from that group, and they may have an affiliation locally. That tends to be a medical service that's very time bound and very limited in scope. And I think that's a very different thing than an embedded faith-based structure that's in a community that's been there for 100 years and that has been providing services to the community. I think they're going to have very different ways of operating and perhaps very different agendas. So I do think we have to piece apart in the countries you're talking about and visiting the types of services and the types of organizations. I actually find, and I spent 13 years living overseas, that most of the time those organizations are very upfront about what they're about. There may be examples that you have found where international organizations do something different on the side and claim, but I don't find that is by and large how international organizations operate. We tend to be in a very clear, people tend to watch us, so it's not like you would sort of somehow that would happen. And I think organizations like CRS are very clear that our mandate from the U.S. Bishops' Conference is to do work to help those in need, not based on religion, not based on race, not based on creed. It's based on the need of those individuals. And so when we partner in any country, and we do not directly implement except in emergencies, so our entire work in 100 countries around the world is all about partnership. We partner very clearly with organizations that share our vision and mission, that what we're about is helping those in need.
We certainly have come across enough issues that we think that this is one of the key areas that needs thoughtful exchange. Andrea Sifa has called itself Interfaith. It's the Center for Interfaith Action. And I think one of the reasons for interfaith is to try, in a sense, to bring faiths together to work on common problems. You have the last word, so do you want to have a quick comment on that?
Sure. Thanks. Our approach has been to bring specifically Muslim and Christian in Nigeria, but additional groups in Mozambique and elsewhere, together to focus on a specific problem, starting with malaria, but now moving into other issues. There's polio work that's being built off the discussions in the program. The benefits of actually focusing on a common problem are that you can speak in your own language, you can speak about from your own faith tradition, and address something that is universal to the national society, to the local society, and we think that by doing practical work on a health-related issue, you can actually build bridges that transcend that health issue, and that's actually part of our long-term research program is to see whether that's actually true. But I think there is hope when you do bring religious leaders together on AIDS, on malaria, or something else, that they actually form a bond that can help relieve some other tensions. So that's part of the work we do. Thanks.
Well, thank you all for very thoughtful comments. We're going to open it up now. Who would like to make a comment? Please introduce yourselves. And I'm sure some of you will have comments as well as questions, but please try to keep it brief so that we can have as many voices as we can. So,
I'm actually going to take the
how are we
microphone
doing
as
it?
well so we can hear.
Good. So,
Thank you. I'm Doyolu Wole. I'm from AED, Director of Africa's Health in 2010. Thank you for the opportunity and thanks for your comments. I just want to say that as an African, I do know that people are not ashamed to stand up for the religion that they believe in. They are not ashamed of their faith. That's one big difference that I have found between living in Africa and here. In Africa, if you are a Muslim, you let people know you are a Muslim. If you are a Christian, people know you are a Christian. You just stand for what you believe in and you are accepted for that. And, even in a family, you may have a mixture. So we've learned to live together. And this faith is central to our well-being, whether it's illness or wellness. Faith is central. So when you find in a community a faith-based organization coming in, you know that they are coming from point of view of their faith. But they are accepted in the community, just like Michelle said, because up front they know what they're going for. And most faith-based organizations in Africa, in my opinion, in my experience, actually work across religion, across race, across creed, across sex. It really does not matter to them who comes to their doorstep. They never turn you back because you do not belong to the faith that has established this. Now, in the places where governments will not go to, you will find faith-based organizations. And if that faith-based health center or hospital decides that every day they have to pray in whatever name, the people who come in there accept them for it. So for me, in my 20 years plus of medical practice in Africa, it was a non-issue. I never found anybody who came and said, I'm bothered because this is a faith-based. Indeed, they accepted them much better than they would accept government people because they showed compassion, which is part of the faith that you've all been talking about. I just thought I should highlight that point as a practitioner, as an African who's lived through it.
Hi, my name's Lauren. I'm with the Institute for Reproductive Health at Georgetown University, and I first want to say thank you to Catherine and Jordana for bringing up the often taboo issue of reproductive health and faith-based organizations. It's an issue that we're looking at right now with the support of USAID, so hopefully the report we come up with will shed a little light on this topic. But my broader question really is, so a strength of FBOs is often the issue of sustainability. They're there to stay in the communities, which is a strength compared to NGOs who are driven by 5-year project cycles. But they're often left out of some of the national dialogue in terms of policy, commodities, resources. I'm wondering if there's an effort to strengthen this coordination between national healthcare and faith-based to sort of harmonize the parallel structures.
That's a really good question. I think in many countries we've seen that the faith-based organizations, the hospitals and the facilities haven't in the past been brought into national dialogue. But what we're seeing now with more health sector plans that the bank is supporting, international health partnerships, that there is much more of an emphasis that when that the health sector is more than the government, especially in countries where FBOs are, providing 70% of the services. So I think that at our, the international agencies like the World Bank, USAID, we are all trying to influence countries to look at the health sector as much broader than just the government. And we're also encouraging, the FBOs, they're sometimes umbrella organizations, that they have a seat at the table and be counted. It's the only way we're going to get real coverage in any country that I know of.
Michelle has something to say, but I can't resist making the comment that we heard at a meeting in Accra a couple of years ago that if you're not at the table, you end up on the menu, which seems to resonate with a lot of people. But the issue is often which table and who comes to the table. And I think it reflects one of the areas that, as an academic institution and as an institution concerned about policy, that there seems to be a lot of experience that's not well taken into account in both global health debates, but also in national health debates, and figuring out how to harness, how to capture this extraordinary richness of varied experience in a meaningful way is the hot challenge of the day.
So I want to just say in parentheses that I hope, Quentin, we can talk to you a little bit about our grant and AIDS relief. I think we have a lot of data that would solve some of your data deficiencies, because in our consortium Futures group has been helping us keep track of what's going on, and we have 220 sites. So we know a lot about what's going on in healthcare, and we can, I think, fill some of that in for faith-based. But one of the responsibilities, AIDS relief, which is funded through HRSA under the OGAC, Office of the Global AIDS Coordinator, so it's PEPFAR resources. We are in our 7th year of operation, and we have currently 190,000 people on therapy. One of our responsibilities as part of that mandate is actually to hand over our $100 million a year program to local organizations within the next 15 months. So we have been working for the last 7 years to make sure that we develop and engage those structures in country at a national level to make sure that there are faith-based health networks that can handle that responsibility of taking on those patients and supporting those facilities in a country. So that means, just as you were Hope was speaking about, there are many times umbrella organizations. Sometimes they are jointly Catholic, Protestant, evangelical, sometimes also including Muslim groups. Sometimes they are separated, Protestant and Catholic. It just depends on the country. But part of our responsibility in our grant has been building their capacity to lead and advocate, as well as to manage these resources.
Let me just add one thing. I think the question you asked to me is the most important question. It is, how do we better integrate faith-based organizations as well as the community-based kind of healthcare into the national plans and the national structures. Now, I think it's better now than it was before. The situation is very different in different countries. Now, I think we all agree that this is needed. There are also a number of other policy issues that have to be looked very carefully at because they actually have a different impact on different groups of providers. I'll just give you one example. Imagine a country that provides a new system of health insurance. And you would have the public facilities that are integrated in the national health systems. You would have the major faith-based providers, and what we are thinking here is the Christian health associations that exist in a number of countries. They would be integrated. Then you would have a number of other faith-based or NGO or others that are not integrated. What is going to happen then is that any effort to reduce cost recovery or improve insurance for the population will then be, if nothing is done, to the detriment of those who are not integrated, and thereby may actually, in some areas, weaken service provision. Right. So it's more than a broad question of integration. I mean, there are almost anything that you could imagine as a health policy that is tried in a country in terms of improving health services may have differential impacts on different groups of providers, and that's why the integration is so important.
Thank you. Sambe Duale, Tulane University, and I also work on the Africa 2010 project. This is an interesting discussion. I just want to comment on the 10 to 70%. The thing is, sometimes we don't know what we are counting. If you are counting the health center, the physical health center and hospital, in some country, you may go up to 60, 70%. But if you are counting the woman leader giving nutrition messages in churches, and then your number will be different. So I think there have been some initiative to really quantify the religious health asset in Africa, because when we all know they are contributing a lot, faith-based organization, but we need to know what we are counting. And this is what some people are telling the religious organization. You want to sit at the table, but bring your numbers so people know what you are really doing. So the number will always be a range. We will not be able to really know what the exact number. The other thing is, I think when we talk about religion and health, especially as far as Africa is concerned, I think we mean to bring some historical perspective in the discussion also. If you take a country like DRC that I know very well, you know all that went on during the colonial era. The church, Catholic, Protestant, they were going in to evangelize. And one of the ways is to show that I have a health hospital, I have a health center. But with Presbyterian, it is different. They are going in not to conquer, but to provide services. So we need to have some historical perspective in it. And one final comment, I think was, you need to understand the language of the people you are working with. And religion in Africa is just part of everybody's life. If you are coming with your lenses and not putting people's lenses on, and then you may have a different interpretation.
Both of the last two questions and comments get at a technical question as well of mapping what assets are out there. And CIFA, together with the WHO, and Quentin was a part of this dialogue, and actually I was not, but Quentin was, about a year ago in Geneva, hosted a conference talking specifically about this issue. How do you actually integrate and get an inventory and a better sense of what faith-based health assets, including clinics and hospitals and a range of issues, how do you get that into the database so that the public, the Minister of Health and his or her team actually know what the assets are and how to and are actually in a position to be capable of planning an integrated health system that addresses the population's needs, but accounts for what's actually on the ground. So, and I know Catherine's group has done a lot of mapping work as well, and it's something that I think continues to be a priority.
Mapping is a big issue. It's of course, it means different things to different people, but it essentially is, let's understand much better what's happening historically, geographically, medically, quantitatively, etc. Are there other comments or questions?
Chris Williams, I work on the America Abroad team with Jordana. I had a question, Michelle, about the mission trips you made reference to that kind of go over there maybe once every couple months or years. Are these trips helpful in a different way than kind of the groups we've been talking about, and are they detrimental in some ways as well?
I'm not talking about mission trips that CRS would sponsor or anything, so I would only be, so please understand I'm not sort of grouping them together. I'm speaking more of personal experience, having lived in Africa for 7 years and sort of seen these trips. I think that the reality is of the world we live in is that there are a lot of people today who want to connect, and that many different groups are trying to find ways to create that community and that linkage, whether it's with Haiti or whether it's with Ghana or Nigeria. So I don't want to in any way speak badly of that desire. And I think people are driven for that desire to connect to Africa or to places where there is need, and then they want to provide a service. So I think you have people driven by that desire. Maybe the mechanism in which they're doing it could be improved, but I want to recognize that it's coming from that desire, I think, as the originating point. And I think all of our challenge is, all of us, I think, want to see higher quality of life in Africa. We want to support what's going on in Africa. I personally think there are better mechanisms to encourage community-based empowerment so that the community is deciding what they need and helping engage with the government and community organizations to change their lives. So to me, I would definitely approach it from a different perspective.
I would say, though, that there are still so many different types of groups that are doing that there were certainly people that I spoke to that were kind of doing it the old way, where they would send people over, bring in some medicine, maybe outdated medicine, and leave. But there are plenty of, I spoke to plenty of local in the U.S., local church leaders who are leading these trips, who are starting to understand, who are thinking differently, and are kind of understanding that they need to have a longer-term relationship with the community and look at other aspects like digging, like wells and water and other things that create a healthy community. So
Hope actually has to leave to attend another event, so feel free to, you're trying to duck out. But thank you so much, Hope, for participating. Very much appreciated you having you here.
I have a memorial service that I want to
Just quick, going back to the HIV/AIDS, our understanding of the HIV/AIDS epidemic is evolving, and I think the attitude of the religious leader in Africa were also shaped by some of the earlier information and understanding of HIV/AIDS. So as things evolve and the dialogue is improving, I think things will also change.
Any other questions or comments? Well, if not, then let me thank the panel, thank American Media Abroad, and thank all of you so much for coming. I saw lots of heads nodding, a few heads shaking. So I think this is a topic that's of keen interest, and we'll hope perhaps we can continue the exchange in different ways.